So welcome, Professor Bush. I will hand it over to you for your presentation, and I'm very much looking forward to it.
Thank you very much for that very kind introduction, and thank you for inviting me. I have no conflict of interest with regard to this presentation, and I'm receiving no personal fee for doing so. The conflicts is actually in my mind, the ethical conflicts. It's difficult, but I hope it may produce some interest in the audience and be of some value. So I'm going to utilise the excellent existing documents to give an ethical framework. I'm going to talk about NIV, but also talk about the setting of no active support and tracheostomy, because we've always got to be clear what the exit strategy is going to be. I'm going to try to give a modern perspective, stressing how the goalposts are moving far and fast. And we're also learning that our knowledge is imperfect. I'm going to put forward my personal practice here. Hopefully, it will be the basis of some useful discussion. So the Royal College of Pediatrics and Child Health have issued an ethical framework for withdrawing or withholding life-saving treatment, and it's a document that I commend to you. The typical withdrawal scenarios when we decide not to go forward, curative treatment has failed, like a cancer. Remorselessly degenerating, usually metabolic or neurological condition, and I've underlined the ones that particularly impact on me and NIV. Chronic disease with slow degeneration reaching the end stage, and Duchenne dystrophy, although this is really now becoming an adult disease. And a stable underlying condition such as cerebral palsy, but with increasingly frequent PICU admissions. And the Royal College says that withdrawing or withholding is justified when life is limited in quantity. If treatment is unable or unlikely to prolong life significantly, it may not be in the child's best interest to provide it. So brainstem death, imminent death where physiological deterioration is occurring, and inevitable death where death is not immediately imminent but will rapidly follow, and where prolongation of life by life-sustaining therapy offers no benefit. The second is when life is limited in quality, including situations where treatment may be able to prolong life significantly but will not alleviate the burdens associated with disease or treatment. Burdens of treatment, where the treatments outweigh the treatments themselves produce sufficient pain and suffering to outweigh any potential or actual benefits, and the burdens of the child's underlying condition. And the severity is such that it produces such pain and distress as to overcome any potential or actual benefits in sustaining life. And finally, lack of ability to benefit if the severity of the child's condition is such that it is difficult or impossible for them to derive benefit from continued life. And I would most strongly commend this humane and scholarly document to you, issued by the Royal College of Pediatrics and Child Health, and I can commend it completely impartially. It was nothing to do with me, but it's a really good guide to anybody in these vexatious problems. The college also stresses rightly it's essential to invite parents in these discussions, and the court's opinion should be sought if there are irreconcilable differences between parents and professionals. But it's always worthwhile, get a second opinion, think about a formal mediation process. And the courts are going to heed the parents' views, but the child's best interests will be paramount and determinative. As professionals, what have we got? What are our responsibilities? Well, the principle of sanctity of life is not an absolute one. There is no obligation to give futile or burdensome treatment, and we are not obliged to provide such treatment even if requested. But again, stress again, second opinions and a formal mediation process may be useful. And the responsibility for determining what is indicated clinically lies with us, the professionals. And we can make decisions for those who are unable to make them. So what do parents want? And this was a qualitative study of 25 bereaved parents, and they felt they wanted the doctors to provide information without opinions, giving information and advice. They don't want decisions taken out of their hands if at all possible. And they want us to be affirmative of parental decisions and follow up with support and appropriate referrals. Of course, in terms of stressing what the parents want, I really must stress that it's important that the child is the centre of this, and the child is my patient, not the parents. Can second opinions help? Well, the usual context, and I've given a number of second opinions. I'm asked to see a child who's been looked after to superbly high standards, and every possible avenue has been obsessively explored. Just occasionally, somebody coming in, an outside helicopter view, will uncover something missed, but this is the exception. In my area, it's usually about ceilings of care. Where does NIV come in? Reintubation, tracheostomy. And you might ask, what can I offer in another unit that the home team may not have, and I don't have in my unit? And the answer is unhurried time. We're usually extremely busy, rushing around with lots of patients. And if I'm going to give a second opinion, I'm able to write off a morning or an afternoon just for that child. And the other useful device I have found is the mobile phone. Very often, parents will have pictures, videos of their child, which will give you a clues as to their quality of life, and they're very often very keen to share those videos. And in this case report, this was a 9-year-old girl who had established neurodisability, and everybody conceded she had a progressive, degenerative metabolic condition and was going to die before adult life. She'd been stable for a long period at home, had a respiratory collapse, was admitted to PICU and ventilated, and she was effectively and brilliantly treated but remained ventilator dependent and repeatedly failed extubation. And they'd done everything they could possibly do to facilitate extubation. And the PICU team and the review board, the institutional review board, said withdraw care. But the parents wanted a tracheostomy. So where do we go from here? So I was asked to give a second opinion. I could find no new medical intervention. But what I was able to do is to spend, with the parents' permission, a long time looking together at pictures and videos of X's home life. And it was very clear that although she was severely handicapped, she had a good quality of life and was an important part of the family circle. And interestingly, I actually spoke afterwards privately to the chair of the committee. They hadn't seen these videos, and they hadn't spoken to the family before reaching a decision that tracheostomy was not indicated. So what was my opinion? My first opinion was if the family fight this in the courts and they show these videos, the hospital will lose. And therefore, we should try to get her home with a tracheostomy. And she did go home and was invasively ventilated at night through her tracheostomy, was off the ventilator during the day, and resumes her previous quality of life. And for me, the learning points of this for giving second opinions, for the family, if the family are happy to share, look at the pictures and the videos. Much the best way of judging quality of life. I've never yet had a refusal, had a family who didn't want to show and talk about their child. And I think it's really essential for those making decisions to talk to the family. And if you go to the ethics committee, after the institutional review board, maybe the family would find it daunting to interact with a full committee, but a member should offer to visit and talk to them. And again, we come down to the question, who is best at determining quality of life? Is it the parents? Is it the professionals? Or who is it? What about legal opinions? Well, in some cases, it may be inevitable. There are some religious groups who very sincerely are unable to withdraw treatment, and the courts taking it out of their hands may actually come as a relief to them. And seeking a legal opinion, in my view, should not be seen as a sign of failure. Definitely not. Start the process early. The family court judges, without exception, I've been hugely impressed with them. They always have the best interests of the child at the centre of their judgment, and are not really interested in legal fireworks. And it should not be seen as a win-lose process, but actually seeking an outside wise opinion as to what is the way to go. And the courts are going to balance the likely quality of future life for the child with and without treatment, the intolerability of treatment or outcome, relevant clinical considerations, the pain or suffering caused by the treatment, and the pleasure a child may derive from its current life, including the child's awareness. So what now is the 21st century reality? And this is these are two tragic babies. You may remember reading about them: Charlie Gard at Great Ormond Street, Alfie Evans at Alder Hay. Severe neurological illnesses, in intensive care, ventilated, multiple painful procedures, and parents demanding everything should be done. Tragic situation for them. Social media allowed all and sundry to comment, including the Pope and President Trump, the latter that well-known ethicist, and some to actually violently abuse staff. There was posturing by professors who wanted to publicize their experimental therapies, and prolonged expensive lawsuits while the baby's suffering went on. And this is a really shocking, these are actually a police protection for a children's hospital, because Alfie's army, a bunch of people who took it upon themselves that they knew best what was best for Alfie, and they were going to protect him from having his treatment withdrawn. Really shocking illustrations. And there has to be a better way, maybe a quicker involvement in mediation or some independent review ethical body. We must not prolong useless suffering and expend lots and lots of money to no useful purpose for the children. The only person who benefits are the lawyers lining their pockets. And doctors need to understand their professional responsibilities and not encourage false hopes with bizarre treatments that have only been tested in animals. And there are, for me at any rate, there are more and more worries about social media and what is said there. Is this a form of electronic mob rule? And the more powerful that modern medicine becomes, sadly, the more regard is paid to internet quackery and witchcraft, a real failure of education. So when we were very young, Duchenne muscular dystrophy, how did it all start? Well, a long time ago in a galaxy far, far away, for Duchenne dystrophy, the onset of hypercapnic respiratory failure was the messenger of death. They were all dead very quickly. And they died hypercapnic with blinding headaches, unable to concentrate on their schoolwork, a very poor quality of life. And it caused a scandal at the time. Outrageously, some of these patients were offered NIV and they felt much better. And the practice of NIV went on. And there's a lot of criticism. Surely this is just prolonging the period of dying. But they refused to die. These are Anita Simon's data, and you can see the percent survival. Bear in mind that these patients you'd expect all to be dead within a year. They are now living out to 6 years. And they had an acceptable quality of life. This is the SF36, and you can see that the black bars are Duchenne dystrophy compared with scoliosis, with polio, with COPD, and in all relevant domains, their quality of life was comparable to COPD patients. And the data are, in terms of quality of life, that professionals and even patients and carers consistently underestimate the actual quality of life as perceived by the patient. And the disabled are increasingly and rightly rejecting the right of people like me to tell them what their quality of life is. And I was very struck by hearing an adult physician talk about the Danish Duchenne muscular dystrophy program. In this program, Duchenne muscular dystrophy patients, if they want it, are electively tracheostomized. They have their own budgets for cars, computers. They hire their own 5 carers. And this is not his patient. When I got off the internet, he saw a Duchenne dystrophy patient who said to him, I have always wanted to do, he was trach ventilated in a wheelchair. I have always wanted to do a bungee jump. What do you think? And he said, well, as your physician, I think you're absolutely out of your mind. And he said, yeah, I knew you'd say that. But now, as my friend, what do you think? And he said, you should do it. So this guy did a bungee jump on his trach ventilator in his wheelchair and loved it. He fractured his femur on the way down, but he said, I've got to sit in a chair anyway. What does it matter if my thigh's broken? So these guys are incredible, and we really must not assume that we know best about their quality of life. So the parents now and patients are but literally boldly going where no one has gone before. Survival is very prolonged. The quality of life is good. And increasingly, elective tracheostomy is being offered to these patients. And I would put to you that actually, is it possible to withhold under any circumstances NIV from a get-it-competent teenager with Duchenne dystrophy, unless there are other reasons why it's wholly futile? What about quality of life? JB is born premature. His mother was in a road traffic accident, suffered a big placental abruption, and he came out in a shocking state, severe cerebral palsy, unable to communicate at all, or so it seemed. And then, I'm sure we all know the game, walking around the garden like a teddy bear, and his father was doing this game with his son, and suddenly said, he's anticipating being tickled under the chin. And this was the first sign that this child actually could communicate. And if you do nothing else, get hold of this book and read it. This is the boy's autobiography. He wrote by eye pointing, and it is very clear that his appreciation of his quality of life would be completely different from what mine would have been. And it's a really challenging book. It's one of the most challenging books I've ever read. So now let's think about spinal muscular atrophy. A long time ago, a journey of a child with SMA1. She was referred to us from another hospital, aged 10 months. She was stuck on oxygen and CPAP and was not for reintubation. And I was told her parents were the parents from hell. And it was rapidly quite clear why they were the parents from hell, because in the other hospital, they'd found out that the decision had been taken in intensive care not to reintubate their daughter without any discussion with them at all. They just found out overhearing a corridor conversation. Not surprising, they were a bit upset. She had marked respiratory distress, ineffective cough, was normocapnic, and we sat down and talked about quality of life. The parents knew she wasn't going to live forever, but they were keen for palliative home care. So we agreed a written treatment plan, that we weren't going to have tracheostomy. If she needed to be ventilated, we would ventilate her for a short period, and there would be an open discussion to precede all changes. And here she is when she first came to us. And in fact, the physios did all the hard work and heavy lifting. They got her stabilized on non-invasive ventilation at night, and she was off during the day, and she had a good quality of life. And what happened then? Well, she went home with nocturnal BiPAP and a cough assist, and was nasogastrically fed. And age 8, underwent a PEG and Nissens, that she'd been tube fed up till that point because the parents were worried and afraid that of an anaesthetic for her, but she went through the anaesthetic fine. She occasionally needs admission and is now transferred to the adults, age nearly 9, and she's now nearly 19, and she has a boyfriend. So this was a challenge, and this was now long before the new treatments, but this shows what can be done if the parents and the child want it with BiPAP and other treatments. So, respiratory support of a non-intubated child. What's the approach? Well, I mean, the first thing is to say you've got to be open, talk openly with the parents and child about options. Don't try to conceal anything, because they will find out, and if they think you've concealed stuff, they won't trust you again. They won't trust you again, ever. Get a multidisciplinary assessment, involve the whole team, involve the psychologists. The parents may have guilt feelings. It may be helpful to meet another family to discuss what the implications of treatment are. And the aim for me is to try to make a written plan effectively, rather than try to make decisions on the hoof at a time of emergency. And things like, right, if there's an acute deterioration, are we going to intubate? Cardiopulmonary resuscitation or not? Tracheostomy or not? None of we accept, obviously, that the plan is fluid and not fixed, that it can be changed, but only after open discussion. And actually think carefully about what will success look like. What does success mean? And in thinking of the child, it's also important, the direction of travel may be as important as the start point. The fact that the child I discussed who went home with a tracheostomy, the fact the start point was a good quality of life and the direction of travel was stable, was at least temporarily, it was encouraging to do the tracheostomy. And we've also got to be aware of how survival trends have changed. So this is SMA1 registry data and a questionnaire survey, and you can see here, whereas in 1980 to 1994, a rapid deaths, a few longer survivors, but by 1995-2006, just on standard treatment, the 50% mortality rate had been pushed out to 10 years. And it's really important that we actually know what the current data are and not base decisions on old data which may be out of date. And gastrostomy feeds, NIV, cough assist were significantly what impacted on survival. And this is an old paper, one of Michelle Chatwin's, our initial experience with NIV and SMA1. These were 13 patients with all comers. They all underwent overnight monitoring, and they were offered NIV for different reasons. Some for nocturnal hypoventilation or reversible paradoxical breathing, to facilitate airway clearance, reversal of CPAP or oxygen dependency, protocol-driven extubation, anticipatory care, all these things, and we're clear in our minds and clear with the families as to what success would look like. So one success for some of these better children, success was good quality survival. And NIV used for protocol-driven extubation successes. And very often these patients who'd had an operation, been intubated for surgery, extubated direct to NIV, and subsequently NIV weaned. NIV to enable the patients to get home, sometimes to get home for terminal care at home, for palliation of respiratory symptoms of distress. In some, the chest wall shape improved. And interestingly, as with the patient I showed you, admissions decreased with age. And the long-term survivors, and we've now had 2 or 3 who've transitioned to the adults without having had any of the modern treatments, they're very rarely admitted to hospital. Terminal care may be facilitated in those who are really seriously disabled. And 5 children died, and the parents were asked for feedback about what they thought about NIV. This was informal. It was not a questionnaire. And all of them reported improved symptom control. The child's breathing was more comfortable. And they felt it gave opportunities for quality time at home, opportunities to come to terms with the fact that the child was going to pass away. And one family indeed commented it gave them time to come to terms with the diagnosis at home. And I've talked about social media and some of the things that have changed, and how. But the other thing is the get out of jail card. Is there going to be a new treatment that's coming along that's going to salvage my child? I've got to hang on in there for the chance of a new treatment. And while respecting, of course, that parental understanding, it may not always be healthy. But of course, there are now for SMA get out of jail cards. So the molecular biology of SMA, which is really important in thinking about treatments, all of us have an SMN1 gene which produces a functional SMN protein, survival of motor neurons. We've also been provided with an SMN2 protein, but which is actually non-functional because it has an exon deletion. So what happens is exon 7 is deleted, exon 8 couples to exon 6, and it produces a largely non-functional protein. In SMA, there's a mutation in SMN1. SMN2 still produces non-functional protein, and as a result, you have the disease. And there is now a get-out-of-jail card, the first of which was nusinersen. And this was something that reversed the exon deletion and produced functional protein. A double-blind randomized controlled trial. It's a big deal. It has to be given intrathecally, and the trial had to be terminated earlier because of how good the responses were. So you can see in this panel the event-free survival for nusinersen in the blue line, control in the grey line, and you can see very clearly that nusinersen was highly beneficial. What about gene therapy? And this was a single dose, a peripheral injection of an adenovirus-associated virus, open label, in babies. And the results were extraordinary. 11 out of 12 sat unassisted, 9 rolled over, 2 walked independently, 11 fed orally and spoke, unheard of in the world of SMA. And you can see again here the CHOP score. You can see the dramatic improvements in all but one of the patients. I'm going to show you this 5-year-old boy. So just like I've got the mother's permission to show this video. What's the diagnosis?
Are you ready?
Wow.
Lift your head up. Almost feel like we might.
You can see he's obviously supported in his walker, but you can see he's making efforts.
You're trying so hard to lift those legs up.
Is
aren't
he?
you? Yeah.
So this boy, in fact, has SMA1.
You do it. Go on.
He received gene therapy late,
Look at him.
but look at him by comparison with non-treated 5-year-olds.
Trying to bend his knees and lift his legs. There you go.
But there's a problem. We've got lots and lots of expensive drugs. Can we afford it? His injection of gene therapy cost £1.7 million. And again, in ethics, we're going to have to think about the costs of these new treatments. The way we were, people as old as me may remember the days that rHDinase, pulmozyme, came on the market for cystic fibrosis, and there was uproar because it cost £8,000 a year. Where we are now, more and more complex biological treatments, the modulators, the cystic fibrosis, the biologicals for asthma, SMA gene therapy, £1.7 million. Healthcare is a black hole, and under any political system, any political party, there's going to be rationing, because more and more really effective and expensive treatments are going to come online. And we cannot practice our ethics in a vacuum. We have to consider what we can actually do. Any political party, it's a myth to suppose that everybody can have every medication and every intervention under every possible circumstance. It's not going to happen. What can we do? Well, this is a judgment well worth reading. This was a case from the Supreme Court in South Africa. And the plaintiff, Mr. Subramani, appealed. He was a 41-year-old man with end-stage chronic renal failure. He was unemployed, he was poor, and the money he had to pay for his care was soon exhausted. And he filed suit, which was appealed all the way to the Supreme Court, to obtain public funding for dialysis. And it went all the way to the Constitutional Court. And the defendant was KwaZulu-Natal, where he lived. And their position was that dialysis was expensive. They simply did not have enough facilities to go round to meet all the needs. And so they had a preset policy which restricted dialysis to those eligible for a kidney transplant. And this was conceded by all concerned. This excluded the plaintiff because he had substantial cardiovascular and other morbidities. So the judgment was given in the Supreme Court by Arthur Chaskalson, who was a human rights lawyer in the apartheid era, and Nelson Mandela's attorney in the Rivonia trial, president of the court, a really serious human being. And his judgment is well worth reading. It's on the internet. The hard and unpalatable fact is that if Mr. Subramani was wealthy, he would be able to procure such treatment from private sources. He is not, and has to look to the state to provide him with treatment. But the state's resources are limited, and the appellant does not meet the criteria for admission to the renal dialysis programme. And the case was dismissed. KwaZulu-Natal won the case, and the plaintiff died within a few days of treatable chronic renal failure. And Chaskalson P held that resources were limited and it was not for the courts to intervene, provided decisions were based on rational policy. This is another book well worth reading. Edwin Cameron, who's also a human rights lawyer and a judge in the post-apartheid era, a man who was gay, white and HIV positive, well worth reading. Writing years later, he said he could not see how the Constitutional Court could have found otherwise. And frankly, I can't either. Resources are limited, and that's something we're going to have to tackle for our neuromuscular patients when these expensive treatments come out. So what about the next development? And again, the get out of jail trial for SMA2 and 3 sunfish. You've seen the molecular biology, which is shown on that panel. It's an autosomal recessive, and this study was a trial of oral daily risdiplam or placebo. And the primary endpoint was change from baseline in the 32-item motor function measure total score at 12 months. And you can see there are improvements in the risdiplam group. This is an oral medication, same mode of action as nusinersen, but you don't have to have a lumbar puncture. And the younger you were, the better the outcome. So I'd now like, with the mother's permission, to share with you a video of a boy, of the journey of a boy who went into the sunfish study. The quality is not great, but it improves. George has SMA2. Remember, before the trial started, all he could do was lie on the floor and not do anything. So now he's on risdiplam, and there he is, standing unsupported. And now, latest picture of him. There he is, sitting unsupported. He's the poster boy for the new Asda uniform ads. And here you can see him in his wheelchair. He's in a wheelchair because he's got contractures of the hips and knees, but he's playing the drums. And if you want to know more about him, that's where you can find out. So the goalposts are moving. I'd like to share another case with you which illustrates an important principle of how you shouldn't jump to conclusions. So SMARD is genetically distinct from SMA. It's on 11q13.2 to 13.4. There's peripheral muscle weakness and unilateral or bilateral diaphragm palsy common at presentation. And respiratory failure, usually within 6 weeks to 6 months, and early death is the usual course, but this is not inevitable. And rare cases of prolonged survival with tracheostomy have been described. So V is a full-time baby, full-time normal delivery, born to healthy non-consanguineous parents. And by age 3 months, he's developed progressive respiratory distress and increased work of breathing. She's positive for adenovirus and rhinovirus. The chest X-ray you can see here, very abnormal. Look at those high diaphragms, a lot of atelectasis, particularly behind the heart. And the CT scan, again, you can see the abnormal chest shape and evidence of aspiration. And she comes to us, she had some soft peripheral neurological signs and unilateral, then bilateral diaphragm weakness. And she remained weak and listless. CPAP was no good, and she went on to BiPAP via a nasal mask. Remember, we don't have a diagnosis at this stage, and she's totally nasogastrically tube fed. And she's referred for a neurological evaluation and returns with a presumptive diagnosis of SMARD, but awaiting genetic confirmation. And the family, perfectly reasonably, didn't wish for discussions until diagnosis was confirmed. So we prepared the family, anticipating bad news, and the family support worker came in for the picture and came to the interview. But now we've got a problem. This baby is much more active and alert. The physios have sorted her out on BiPAP. She's on continuous NIV. She's smiling and splashing around in the bath and looks great. So she is SMARD gene positive. Grief and tears at this news, and the family need time and space to think about treatment options. And we always stressed at the initial, this is going to be a partnership, and that their ongoing central role in her life was going to be stressed. So what are the options? Optimal medical management, airway clearance, secretion management, and opiates for respiratory distress. Nasal mask ventilation for palliation or nocturnal hypoventilation, tracheostomy, and time for reflection was offered so the best options could be chosen. Don't make a decision before you have to. So they decided they wanted to continue, but given the bad prognosis, not with a tracheostomy, but 24/7 BiPAP, on which she was comfortable with a good quality of life. And for her nutrition, she had a PEG and a Nissens fundoplication. And we capped care, but they said, we would intubate if she acutely deteriorates. And there was a written plan, and we decided our goals and what would be success and failure. So what happened next? She went home by NIV BiPAP, and reviewed a few months later. She's going through motor milestones like they're going out of fashion. She's crawling. Other than her bilateral diaphragm weakness, she is totally fine neurologically. Virtually no tolerance of disconnection from NIV. What do we do now? Do we carry on with NIV and hope when she's upright she'll be able to breathe spontaneously? Perform a tracheostomy? Do something else? Well, we then decided after discussion with the parents that she should have a tracheostomy because she was clearly not behaving as you would expect from a SMARD child. So what are my final reflections of this? What are my take-home messages? The first thing I think is a lot of these neurological conditions are a very wide spectrum, from antenatal onset with virtually no movements from birth to onset of several months with anti-gravity power. And rather than apply labels, look at the child. Labels may not be useful, and SMA1 could comprise a child who's born completely without any muscle power at all, with antenatal onset, to somebody who did well for several months and then developed the disease manifestations. Define function and progress, good or bad, rather than hide under an umbrella term. So the last patient I showed, is she a SMARD patient or primarily an infant who has SMARD? And in 2023, there can be no preconditions to discussions and no paternalism. You'll be rumbled. The parents will go on the internet. They will find out for themselves what the options are. The idea, well, I won't tell them about tracheostomy because it's not appropriate. That does not wash at all. You have to put all the options out there. Talk to the parents, ruling nothing in or out in the first instance. The child, however, is our patient. And the college framework, which I started this talk with, is, in my view, an excellent guide. Don't try to reach decisions too early. Give everybody time. Define goals. What will success and failure look like? Define as far as possible the exit strategy with advanced planning. And perhaps the most challenging child I ever looked after was somebody who came from abroad with 18 months with a tracheostomy and a G-tube in place and an undiagnosable neurological illness which progressed so that this child was completely paralyzed. Mother could only had to open and close his eyes, and he could only communicate with his heart rate and lived like that for more than a decade. So think before tracheostomy. But it's also important, if families want to push back against accepted boundaries, ask whether you know how the boundaries are set right. And remember, that's how progress has been made. Families saying, I don't care, we want to push against the boundaries. That's how leukemia treatment has progressed. That's how Duchenne dystrophy survival. But it does come with a cost. And again, a personal case, a boy with Duchenne muscular dystrophy who went to the adults and opted to have a tracheostomy. The tracheostomy was put in by a superb surgeon, and a week later, blood started to come up his tracheostomy tube. I don't know whether he bled to death or drowned in his own blood, but he died suddenly, a very horrible death that would not have happened if he'd refused tracheostomy. But he wanted to push the boundaries and maintain trust. The definition of a grey area is not that the parents have to do what I say. And who has the problem? Who should judge quality of life? And I keep coming back to that. Should it be doctors? Should it be ethicists, parents, the child, if they're able to express themselves? One of the things I've learned over the years is I'm really not qualified to judge quality of life on any more than anybody else is. And remember, in the modern era, we're on unknown territory. We're unknown new treatments. We're going beyond the textbooks. And this is something that professors ought to repeat to themselves every day. Oliver Cromwell, I beseech you, in the bowels of Christ, think it possible you may be mistaken. Don't be so sure that you know the right way forward. And very importantly, take care of your team, take care of yourself, because these are very tough issues. They can be made much worse by social media, much worse if it progresses to confrontation. So I don't have many answers, but the issue is going to get more, not less common going forward, as medicine can do more, as expectations are higher. Complete openness, transparency, and humility are absolute prerequisites. And the family have got to be happy that their voices are being heard and heeded. And if you have one, I certainly think review by an independent hospital ethical review committee is incredibly valuable. But it's really important that they must also talk to the family. They cannot just give judgments without having really understood the family's perspective. Of course, get second opinions. It's not a sign of weakness to get a second opinion. It's a sign of strength. And above all things, maintain trust, because once you lose the family's trust, it will never come back again. And survival is changing. SMA2 now 80% surviving into the 4th decade of life. Duchenne muscular dystrophy, half of them are surviving into their 30s. Some of them are into the 40s, depending on when Duchenne dystrophy ventilation was initiated. And if you look at the graph, many of these curves appear to have hit a plateau. That yes, some children sadly die early, but those that don't, it seems to be it's not a continuous rate of attrition, but they may have plateaued out for long-term survival. So I'd like to thank the many collaborators, funders and supporting centres, children and families, particularly the multidisciplinary team and the physiotherapists who actually do all the grunt work on this. I'd like to thank you for listening. These are my grandchildren that taken a few years ago, some of them a few years ago. And I'd like to finally end by highlighting this talk. The next talk is going to be Dr. Michelle Chapman, who's been a friend and colleague for many, many years on peripheral airway clearance. Thank you very much indeed.
Thank you very much, Professor Bush, for this really clear presentation. I think a lot of very important issues have been spoken about. We have a number of questions that came in, but before that, I'd like to mention to all of you a comment we got in the chat from, I hope I pronounce it right, Andres Almario, who says, "Thank you so much, Professor Bush, for this very clear and honest session. Just wanted to highlight the recent report by the Nuffield Council on Bioethics, which is also worth reading. And I think the link can be found in the chat as additional reading material."
Yes, I again completely agree, and there are a number of very good ethical documents out there.
So far, there are 4 questions which we got in. One is a question like, a care team is most of the time a multidisciplinary team. Do you have experience with parents kind of asking around to different members for their opinion until they find somebody who shares or supports the parents' opinion? And what do you do in such a case?
It's really important. Communication is key, and as a team, we need to agree what the message is, and it may take time to agree. And once we agree, it's really important that we all say the same message, and preferably, actually, in these complex cases, there just be one person who is the conduit of information to the parents, because you can understand. Of course, the parent, if I've told the parents something terrible, of course they're going to want to find somebody else who's going to say, no, he's quite wrong. Everything's all right. But so absolute consistency is key. But the person communicating doesn't necessarily have to be the doctor, but it's probably a good plan if you can get it to have one person. And also, we find it useful to have regular scheduled meetings. So we'll say, okay, for a child who's going to be in for several weeks or even months, let's meet every week or every 2 weeks, the parents and one or two professionals, so we can update progress.
Yeah, that makes absolute sense. A shorter question: should clinicians give advice or only information?
I think it is a myth to think that clinicians can give information in a completely objective way. I mean, if suppose you have a child who is facing heart surgery, the way I phrase the information could either frighten you off completely, or you could sign on the dotted line. You should certainly try to be objective. I try to, when talking to parents, I try to divide what I'm saying into things for which there is clear-cut evidence. And one illustration, for example, in the world of TB, we know that 2 months treatment with 4 drugs and 4 months with 2 drugs will cure you. And you'd be, that is fact, that is evidence. But also differentiate that from the grey area where you don't have evidence, and where acknowledge that different, equally loving, equally intelligent parents reach different decisions. So I give the options. Very often I'm asked, what do I think should be done, and I will give an opinion then, but stress the level of evidence on which I'm basing it. And if it's genuinely a grey area, I will say so and say, look, you don't need to, you may not agree with this, and if you don't agree, that isn't proof of malign behaviour or stupidity or anything. It's because there is genuine uncertainty about what to do.
Yeah. Another question on the pharma you touched on, and all the new molecules and therapies that come out. Is it not unethical by pharma to develop these medications which are inaccessible to the patients?
So it's a very difficult question. I mean, I think there is a wider context. And we see it, I think, because I know the field reasonably well, in cystic fibrosis, where we have highly effective treatments that have been a real breakthrough, and breakthrough is a word that's chucked around very lightly, but they cost about £200,000 per patient per year. And we can get this, our patients can get this free on the NHS, which is wonderful. But there are many parts of the world where these medications are not available. The countries simply cannot afford them. In a low and middle income setting where their priorities would be respiratory priorities would be community acquired pneumonia or TB or HIV. And I think that we have as a community to find a way to reward those who have developed these drugs, because they're gambling a huge amount of money. You could spend £100 million developing a drug, and the last round of rats develops liver cancer, and you've lost all that money completely, and nobody's going to give you any compensation for that. So they have to get their rewards, but we also have to find a way as paediatricians of making sure that this sort of inequality does not continue. And I don't know how we do it. Going back to South Africa and Edwin Cameron, he was a very active campaigner for getting affordable, high-activity antiretroviral therapy into South Africa, because he had a judge's pension, he could afford it. But for the black South Africans or the many heterosexual South Africans largely who couldn't afford it, he made an active campaign and actually won that fight. And I think that's something we've got to do, and take a more global perspective than thinking, okay, we can get it on the NHS, we're all right, Jack. Tough luck for the rest of you.
Okay, yeah, well, yeah. While you're mentioning South Africa, maybe that's a good bridge to the next question. There's a question here, whether in your opinion there are regions in the world that handle this better or worse than others.
So there are many regions where things are handled worse, not because the doctors and nurses and physiotherapists don't know what they're doing, but they just simply don't have the resources to do it. And there are also areas where perhaps religious beliefs mean that, for example, withdrawing treatment is something that genuinely, with a good conscience, they cannot do, and that's a very difficult situation. I've never worked in one of those situations. I would find it extremely difficult if I was in that position. And that, again, coming back for the courts to say, okay, to the family, you want us to keep going. I actually don't think we should. So let's get somebody completely independent to take a helicopter view and have a look and decide what is the right thing for this child. Okay.
I think we can go to our last question, which we still have. Have you ever experienced a situation where a brother or a sister has a similar genetic or other disease than the one which the decisions has to be taken, probably maybe a younger brother or sister, and how to handle such a case?
It's extremely difficult. I mean, I have had some experience. Part of the difficulty is that if you've got two children who are technology dependent, the burden of care on the family is absolutely colossal, and that has to be respected. There is no doubt that the affected sibling needs care. But also, actually, one of the things I remember reading an article by the sister of one of my patients with another condition about what she called glass children, the normal sibling whom nobody thinks about. And if all the focus is on the handicapped child, it's very easy for people to forget, that the normal child has their own feelings, their own needs, their own sense of guilt, perhaps that they are well and the other child isn't. Perhaps their resentment that this child's getting all the attention and there's none for me. So yeah, it is exceedingly difficult, and it must be also needs careful handling. If the younger child sees the older child going downhill and thinking that's what my fate is going to be, that's actually one of many reasons you need a multidisciplinary team. You can't do this on your own. You need the physios, you need the psychologists, you need the play therapists, you need the specialist nurses if you're going to support the family and give holistic care.
Thank you for this answer. Absolutely, I think it's a field which probably doesn't get enough attention in webinars or congresses, but it's of extreme importance, I think, and it should absolutely not be underestimated, the impact for caregivers, family members, patients themselves, and everybody involved, of course. So thank you very much, Andy, for this clear and very interesting presentation about this topic. Thank you to all of you who attended this month's webinar.